Good afternoon, everyone, and welcome to today's webinar, Immune Tolerance in Transplantation, the Holy Grail or an Attainable Goal. We're glad that all of you could join us, and we have a terrific presentation planned for you today. My name is Corey Bryant, and I'm the Communications Manager for the Alliance. Now, we have just a few logistical items before we begin today's program. So for those of you who have never joined us on this webinar platform before, the chat feature is located in the bottom left-hand corner. If you have any questions that come up during the webinar, please feel free to submit them at any time. And once the presentation is complete, we'll have some time for our presenter to address as many of your questions as time allows. We are recording this webinar, so that means we will not be opening the phone lines. That means all questions must be submitted electronically using that chat feature in the lower left-hand corner. Registration is currently open for our upcoming Get Connected webinar entitled Building a Culture of Donation Through Effective Hospital Association Partnerships. That's going to be on April 10th at 2 p.m. Eastern Time. Registration is also open for our upcoming transplant webinar, The Opioid Epidemic, Organ Donation and Organ Transplantation. That's on April 19th at 3 p.m. Eastern Time. So you can register for those webinars and more by logging on to our website at organdonationalliance.org. For today's webinar, we are awarding 1 CEP-C credit and 1 nursing contact hour courtesy of Iowa Donor Network. Everyone listening on today's webinar is entitled to claim continuing education credits. If you are listening in a group, and we know that many of you are, please make sure to get the evaluation email from your group lead. It's a very brief online evaluation which will allow you to receive your credit. Now, as a reminder, for nursing, you have 14 days to claim your CEs, and for CEP-Cs, you will have 30 calendar days. So at this point, I would like to introduce the moderator of today's webinar, my friend and colleague, Haiti Aguiar. She is the Senior Director of Programs here at the Alliance. So Haiti, without further ado, I will hand it to you.
Hi, Corey. Thank you so much. Welcome to everybody on today's webinar. I am so thrilled and excited to introduce our speaker for today and count it a real privilege that he accepted our invitation to share his expertise. Dr. Gerald Brandacher is an Associate Professor of Surgery and Associate Professor of Plastic and Reconstructive Surgery at Johns Hopkins University School of Medicine. He also serves as the Scientific Director of the Reconstructive Transplantation Program at the Johns Hopkins, and his team is engaged in basic and translational research on donor-specific immune tolerance and immunomonitoring strategies for vascularized composite allotransplantation, such as hand, upper extremity, and face transplant. Prior to joining Johns Hopkins, Dr. Brandacher was a key member of the hand transplant program at the University of Pittsburgh Medical Center. Excuse me. He was instrumental in designing a novel cell-based immunomodulatory treatment protocol for composite tissue allotransplantation, and was also part of the team performing the first bilateral hand transplant and first forearm transplant in the United States. And then Dr. Brandacher has mentored 60 pre- and postdoctoral researchers over the past 15 years. He has authored more than 180 peer-reviewed papers, 27 book chapters, and has edited 2 textbooks on hand transplantation. So as you can tell, we have a real expert on our hands here. In 2014, he co-founded the journal Vascularized Composite Allotransplantation and currently serves as the editor-in-chief. Dr. Brandacher is the principal investigator of multiple major federal research grants on projects related to upper extremity transplantation, cell-based immune modulation, and tolerance induction. He has given over 130 invited lectures and has been a visiting professor around the world and at leading American medical institutions. We are very lucky and appreciative that he has made the time to share his expertise on immunotolerance on today's webinar. And Dr. Brandacher, thank you. We're really eager to hear what you're going to be presenting to us today. I'll turn it to you.
Well, thank you very much, Hedy, for the very kind introduction. It's my pleasure and privilege to present today on this webinar and to share with you a little bit our experience with immune tolerance in transplantation, and also share with you the story of searching for the Holy Grail in this field and probably also give you a little bit of a future perspective of where the field with regards to tolerance induction might be headed. And with that, I think we want to go to the first slide, please. Can I have the first slide? Okay, so to start off with, I think it's important to remember ourselves that the idea of transplanting organs or other body parts seems to have always been a dream and one of the wild fantasies of mankind, and eventually it has developed into one of the greatest success stories in medicine in the last century. As we see on the next slide, is that we owe it to the constant and new development in surgical techniques and more potent and more sophisticated type of immunosuppressive agents over the past 60 years that really have enabled us to perform more and more complex type of transplants, such as starting out with kidney and pancreas, liver and heart, lung transplants, intestinal and multivisceral transplants, up to performing vascularized composite allotransplantation such as hand and face transplants today. On the next slide, we see that these advances also enabled us to continuously improve graft survival rates to highly acceptable levels across the board for all type of transplants in the short term. That, however, the long-term graft survival has not really changed over the past 50 years if we look at these statistics. On the next slide, we see that according to a very recent report, more than about 2 million years of lives could be saved in just the past 25 years of organ transplantation in the United States alone. And this is why, as shown on the next slide, this remarkable record of achievement and the tremendous potential to even do more in the future is the reason why organ transplantation has been listed as one of the top 10 medical advances that have changed and in many ways continue to change the world today. But there's one downside as shown on the next slide. The need for lifelong and high-dose immunosuppression to prevent rejection still is one of the major hurdles to be overcome and one of the limiting factors of further advancements in the field of transplantation. On the next slide, you can see that there is a price to be paid for lifelong high-dose immunosuppression, and those are the well-known side effects and toxicities that those drugs entail, ranging anywhere from infectious complications to metabolic complications to even a malignant disease. And just to illustrate again what it means to be on conventional triple drug immunosuppression, on this slide you see the amount of daily oral medication that a transplant recipient needs to take for the rest of his life who is placed on conventional immunosuppression. And for these reasons, as shown on the next slide, there has been a constant search for novel protocols on how to minimize or eventually even avoid the need for conventional immunosuppression, ranging anywhere from protocols that minimize the use of steroids, that minimize the use of calcineurin sparing protocols, the use of newer biologic agents, or more recently, cell therapy strategies. Another strategy, as shown on the next slide, is that really in addition to changing the protocols, we are seeking to pursue novel routes of drug delivery that have been pursued again to minimize the toxicity of the existing drugs, such as the development of micro and nanoparticle platforms, and those have been particularly fueled by innovations in the strategy or in the technology of nanomedicine and advances in our understanding of the underlying pathogenesis of immune-mediated diseases. So on the next slide, you see that the ultimate goal, however, in transplantation, as I mentioned just a moment ago, would be to get rid of immunosuppression altogether and to induce what is called immunological tolerance that actually would come with a setup that would allow us to take a patient completely off immunosuppression and allow for long-term immunosuppression-free graft survival. So on the next slide, this search for donor antigen specific immune tolerance without the requirement of maintenance immunosuppression really has been the holy grail and the ultimate attainable clinical goal in transplantation for the past 60 years, and we have been searching for that holy grail very intensively on multiple fronts. On the next slide, simply I wanted to illustrate what the underlying philosophy is, that really I think for 60 years we have kind of embarked on a wrong journey to use immunosuppression, which is unspecific, counterintuitive, as we have an immune system that regulates itself and does not work only with suppression. And we want to now move towards a more sophisticated way to replace these strategies with more advanced and targeted approaches of immune regulation. On the next slide, you can see that, however, when it comes to actually defining transplant tolerance, that then we are already facing the first hurdle. Tolerance in many instances has been quite loosely described, and the term is also used quite loosely. And it's also known under, for example, operational tolerance. People have called it pro-P tolerance or tolerance with minimal immunosuppression or split tolerance. So on the next slide, I therefore put down for you the definition on how transplant tolerance has been defined by the Immune Tolerance Network, which is fairly straightforward and states that transplant tolerance is defined as the specific absence of a destructive immune response of the recipient towards a transplanted organ or tissue in the absence of immunosuppression and with a fully intact immune system. So I think it's important to highlight really that we need to have absence of both a specific destructive immune response, the absence of immunosuppression, and have an otherwise fully intact immune system in that recipient to truly call a recipient tolerant. On the next slide, I wanted to show that immune tolerance is actually not something that transplantation is trying to come up with. It's something that is real and something that is well established. It's actually one of the most preserved features of mammalian organisms, as shown by the critical importance of self-tolerance and its failure that results in severe autoimmune diseases. When we talk about allotransplantation, then I think the prime example for naturally occurring tolerance mechanism is the setting of an allograft in the setting of maternal fetal tolerance, where the fetus is carried for 9 months. It is not the same blood type, it is not HLA identical to the mother, but it's not rejected. And the immune cells are able to encounter the antigens of the fetus and still can be downregulated. So the tolerance works fairly well. We just need to be able to translate this into therapy for the setting of organ transplantation. And finally, a prime example of naturally occurring tolerance is actually the mechanism of immune tolerance that is harnessed by malignant tumors to escape the tumor immune evasion process and thereby enable to grow and metastasize. On the next slide, you can see that the phenomenon of achieving tolerance through what is called hematopoietic chimerism was actually first described by Owen in 1945. And it was Owen who revealed that in this so-called free Martin cattle, or the dizygotic bovine twins that share a common placental circulation, leading to a naturally occurring state of hematopoietic chimerism, that these animals, once born, they are tolerant to major histocompatibility complex mismatched skin transplants from each other. On the next slide, you can see that building on this foundation, in 1953, actually, Meadow, Billingham, Brand, and Meadow were establishing the notion that the immune system can be deliberately manipulated to become tolerant to a chosen antigen by demonstrating actively acquired immune tolerance through the transplantation of a mixture of allogenic cells, including splenocytes, into fetal and neonatal mice. And this work was actually rewarded with the Nobel Prize in 1953. On the next slide, you can see, I just lost my screen, excuse me. On the next slide, you can see that shortly thereafter already, in 1955, the transplantation of bone marrow into myeloablated recipients was shown to establish tolerance to skin grafts. And these very early studies, they have provided the foundation for using hematopoietic stem cells for the purpose of tolerance induction. On the next slide, you can see that since these very early demonstrations, a multitude of different approaches have been pursued to induce immune tolerance, including the use of mixed chimerism, but also the use of other tolerogenic cells, the inhibition of T or B cell responses, or specific thymic irradiation concepts. On the next slide, you can see that actually when it comes to the clinical reality of transplant tolerance, the data is fairly sobering. And whereas there have been more than 100 different tolerance protocols that have been highly successful in small animal settings, from 1953 up to 2008, none of those protocols has been successfully translated actually into clinical use. And on the next slide, you can see that it was actually chimerism-based therapies and strategies that were the only regimens that could be successfully translated from the small animal setting into a preclinical model. And here is just a couple of protocols that have been listed, that have been developed by the Boston group for both living-related scenarios on the left-hand side, as well as for cadaveric donor situations, which they call a delayed tolerance approach, as you can see here on the right-hand side of the slide. When we go to the next slide, you see here one example of one of those successful tolerance protocols in a large animal setting, where you can see here the histology of a tolerant animal more than a year post-transplant with perfect normal structure. There is no signs of either acute or chronic rejection. It's a perfectly healthy kidney. And you can see on the right side that this response is truly donor-specific, where this was tested with secondary skin grafts that were either coming from the donor or from a third-party control, and you can see that the donor-matched skin graft is taken and heals in nicely, whereas the third-party skin graft is acutely rejecting, which attests that the immune response overall of this animal has not been compromised and is specifically downregulated only against its donor. When we go to the next slide, you can see that much of the appeal of the concept of chimerism actually derives from this observation that the concept could be translated all the way through the preclinical model and is actually now the only experimental approach that has been translated into a clinical setting. There have been several cases that have been documented in which a patient who had received a conventional bone marrow transplant, usually for some hematological malignancies, and subsequently required an organ transplant due to organ failure, accepted an organ transplant from the same donor without chronic immunosuppression. So on the next slide, I want to briefly talk about a chimerism-based tolerance strategy and maybe explain a little more in detail what these approaches entail and what we mean with chimerism-based tolerance strategies. So first of all, as shown on the next slide, is how is chimerism defined? And chimerism means the replacement of either all, and then we speak of full chimerism, or partial, then we speak about mixed hematopoietic cells with donor-derived stem cells, such as hematopoietic stem cells that are transplanted. So mixed chimerism denotes a state of the coexistence of recipient and donor hematopoietic cells following a deliberate transplantation of donor bone marrow into conditioned recipients, with donor chimerisms ranging anywhere from less than 1% up to full chimerism, which would be 100% of donor origin. When we go to the next slide, I've tried to put together for you the concept of tolerance through mixed chimerism. And as I just stated, the concept of inducing transplant tolerance through mixed chimerism is based on a couple of key steps and concepts that are critical to be appreciated for both the barriers as well as the opportunities for tolerance induction. So first of all, we have to start out with a combination of drugs that are administered, and in some cases these drugs include irradiation, either whole body or the thymus or other parts, to the recipient as a conditioning protocol that allows actually the engraftment of the allogenic bone marrow that is then be transplanted. And you can see here that this can either be donor bone marrow or those can be mobilized peripheral stem cells that are then infused into the recipient. On the next slide, you can see that once infused, these donor hematopoietic stem cells which are contained within the graft, that they then engraft in the recipient's bone marrow stem cell niches where they coexist with the recipient's hematopoietic stem cells. On the next slide, you can see that then donor and recipient hematopoietic stem cells are actually lasting and self-renewing sources of donor and recipient stem cells and lineages, which lead to multilineage mixed chimerism, which can be conveniently traced actually in the peripheral blood and thereby monitored. On the next slide, you can see that both pre-existing mature donor-reactive T cells, as well as T cells that escape negative selection in the thymus, are tolerized in the periphery through various different mechanisms, through either deletional mechanism in the thymus or non-deletional mechanisms, which are likely occurring in secondary lymphoid organs, and that the graft itself there can play a key role in the tolerance maintenance towards the donor. On the next slide, you can see that also donor dendritic cells that seed the thymus are critical when they meet central clonal deletion of donor-directed T cells, which then create a T cell repertoire that is tolerant to both self as well as against the donor by being positively and negatively selected in the thymus. So on the next slide, after these basic mechanisms of chimerism, I wanted also to share with you that there is some limitations to these chimerism-based strategies, and those are highlighted on the next slide. First of all, unfortunately, the conditioning regimens that are required to allow for engraftment of donor bone marrow are quite toxic and are thereby a limiting step, which we are currently trying to overcome. And then also due to the requirement of recipient conditioning, tolerance strategies so far are only clinically applicable in a living donor-related transplant setting where we know when the time of transplant is going to occur and gives us the ability to pre-treat the recipient. Also, by using donor-derived hematopoietic stem cells, we induce the risk of developing graft versus host disease, which again is a known complication of the bone marrow transplant, but also in these tolerance strategies is a viable risk. And then also by inducing chimerism, we are somewhat limiting the protective function of the immune system overall eventually, depending on the level of chimerism. On the next slide, I just illustrate that there are some additional hurdles that we need to overcome, and those are summarized in this cartoon that is shown on the next slide, where first there are these specific hurdles, but then there are some general hurdles when it comes to tolerance due to transplant immunology, and those are concomitant infections. There is a heterologous immunity. There is also a memory response, in particular when we talk translating tolerance into humans, and then there is the substantial clone size that we need to deal with when we want to really place in check the alloreactive clones. So on the next slide, some of you might think by now, well, I think rather the glass is half empty than half full when it comes to tolerance induction. But I really want to try to convince you with the next couple of slides that the glass probably is rather half full than half empty. When we go to the next slide, please, you can see that immune tolerance in solid organ transplantation since 2008 has become a clinical reality. There are now 3 centers that are actually actively pursuing tolerance trials based on chimerism approaches, which is the MGH group in Boston, the Stanford group, and the Northwestern and Louisville team. And groups at Harvard and at Johns Hopkins are currently working at tolerance protocols that would be applicable also in a cadaveric donor setting. So on the next slide, I have summarized for you those key publications of the first 3 tolerance trials that are ongoing. And the important fact about all of those protocols is that none of them has been made feasible without the co-induction of hematopoietic chimerism. So I very briefly, as shown on the next slide, want to talk you through the individual tolerance protocols and the concepts that the different groups use when it comes to conditioning, the type of chimerism that they induce, and then also the individual outcomes. So the Stanford group has chosen actually a particular conditioning regimen where irradiation is applied only to lymphoid structures. This has been a protocol that they developed from the cancer patients, and they aim to induce transient or durable mixed chimerism by infusing donor-derived PBMCs, which are enriched for CD34 but have a very low number of CD3 positive T cells. You can see the detailed protocol on the right. It's a fairly elaborate protocol that includes depleting antibodies such as ATG, a series of irradiation sequences post-transplantation, and then the infusion of cells about 10 days post-transplant. On the next slide, you can see in contrast the approach that MGH has chosen. So MGH has significantly reduced irradiation and limits it to thymic irradiation in combination with depletional antibodies to make space for the iliac crest donor bone marrow. So they aim to induce only transient mixed chimerism and not permanent or stable chimerism, as the MGH group considers GVHD as an unacceptable complication for non-malignant patients, and therefore has chosen for this transient chimerism approach. On the next slide, you can see the Northwestern approach, which again is slightly different, as they use whole body irradiation. Their goal, in contrast to the other groups, is to aim for full, complete donor chimerism, and they use hematopoietic stem cells in combination with a specific cell type, which they call and identified as the facilitating cell, which I will show you just in a minute. So on the next slide, you can see this facilitating cell, which was discovered by the Louisville group, by Susan Ilsted's group, and they claim that the facilitating group helps really with inducing chimerism. It prevents the incidence of GVHD in animal models, and it also is helpful to induce antigen-specific T regulatory cells in vivo. On the next slide, which is I think a key slide of this presentation, is you can see here really the summary of outcomes of all of those trials from the Stanford group, the Harvard group, as well as the Northwestern group, in the various different scenarios that they have undergone with either full or haploidentical mismatches. And you can see here that it's important when we look at these outcomes that the incidence of tolerance in none of those trials is 100%. They have great successes and a high percentage of patients being taken off immunosuppression, but neither the establishment of chimerism is 100% in any of those trials so far, neither is the incidence of immune tolerance in any of those trials. And I think it's also important to see that in some of those trials we have seen quite significant complications, such as GVHD or even death in the Northwestern experience. When we look at the next slide, you can see this in a little more granular fashion, where I summarized for you again the outcomes in all three centers with the number of graft losses, and also with detailed numbers on how many patients are still on immunosuppression or were able to be taken completely off immunosuppression. On the next slide, though, you see one example of a highly successful patient that was performed at MGH, and this is one of their early patients that is now off immunosuppression more than 9 years. She's completely immunosuppression free. She's doing great, and she has stated the difference that it can make for a patient to really be completely off immunosuppression and don't have the burden of all the toxicities and side effects. So it's something that I think has shown the successes that can be made and is worthwhile pursuing for these patients. However, as you have also seen, and as I try to illustrate with the next couple of slides, it's still very small numbers for tolerant patients, and one of the reasons for this is that actually, in order for immune tolerance to reach its full clinical impact, we need to work on scalability of these entities. Currently, you see here just the number summarized, about 35,000 organ transplant recipients each year, and there's an additional large patient population who might benefit from reconstructive transplantation. But we don't really historically use donor bone marrow, and it's not recovered for immune tolerance at scale at the current moment. So there's initiatives underway, as shown in the next slide, as this one by OsseoHelp, who is currently developing large-scale clinical immune tolerance protocols by actually banking and recovering donor bone marrow on a scalable range for future tolerance protocols. So on the next slide, I tried to highlight that with these tolerance attempts, really cell-based immunotherapy seems to be the next big frontier in all of transplantation. And another prime example is the ONE study, which is a unified approach to evaluate cellular immunotherapy in solid organ transplantation. And this is a worldwide study. It's coming out from Europe with Ed Geisler as the principal investigator, but it includes centers from the US as well as Europe, and it's really moving forward those approaches significantly. As shown on the next slide, you see here this multi-center approach with leading centers from the US and Europe. And on the next slide, you can see that in these centers, various different cell products are currently used for immune modulation and eventually tolerance induction, ranging anywhere from T regulatory cells to dendritic cells to mononuclear cells and so forth. And the goal there is to first of all prove safety and efficacy of these cell types to allow for reduction of immunosuppression to monotherapy protocols. As you can see on the next slide, so far the reference trial has been completed. There's 6 ongoing cell therapy trials, and you can see the patients enrolled, and this is a very active endeavor that is currently still ongoing. And as shown on the next slides, we will see first data early this year. So far, there have been no safety concerns. They were able to induce safely and successfully tacrolimus monotherapy by using these cell therapy strategies. And there's first evidence also of benefits from reduced immunosuppression that were seen. And there's very interesting and exciting data with regards to immune monitoring results that will be certainly extremely interesting to be seen over the next couple of months. On the next slide, I also want to talk a little bit about other cell types, and in particular about regulatory cell-based tolerogenic strategies that are currently used in addition to bone marrow-derived strategies. As shown on the next slide, regulatory immune cells in transplantation, there are several peripheral regulatory mechanisms that exist to maintain self-tolerance and to prevent the overreactivity of a normal immune response. And we are now harnessing those naturally occurring immune responses to translate them into therapy also for immune regulation in transplantation. On the next slide, you can see that one of those approaches is the use of tolerogenic dendritic cell-based strategies, as these cells are really potent modulators of alloreactive as well as autoreactive T-cell responses, and there's various different studies going on preclinically as well as now first clinical trials that use those cell types for immune tolerance successfully. On the next slide, you can see that T regulatory cells are another key component in those overall regulatory mechanisms of the immune system. And those T regulatory cells can really interfere potently with various different mechanisms within the immune system to downplay an alloimmune response. And on the next slide, you see that there is currently multiple studies ongoing using these cell types in various different scenarios, and I've highlighted on the next slide a series of them that are currently applied in transplantation. Although I think there is still some discussion and some caution to be warranted, as publications of T regulatory cells infusion in non-human primates report some conflicting findings. But overall, I think a very promising approach for the future that we definitely need to have moving forward. On the next slide, you see some limitations of regulatory cell-based therapies, which is a paucity of cell numbers and the need of expansion, which comes with a lot of technical difficulties to really, again, scale these approaches. Then also the purity of the population that can be transferred sometimes limits these approaches. then it comes also down to which particular type of T regulatory cells, whether you choose polyclonal, antigen-specific, donor versus recipient-derived cells, the stability of regulatory phenotype of those cells once infused and over time, and then also the compatibility with currently used immunosuppressive protocols is of importance when we talk about those strategies. When we go to the next slide, you can see that another exciting prospect for the future of cell therapy is the use of chimeric antigen receptors for the generation of alloantigen-specific T regulatory cells. And as shown on the next slide, Dr. Leving's group has actually recently demonstrated the feasibility to redirect T regulatory cells to a transplant-relevant antigen with CAR, and has provided first proof of concept that those CAR Tregs have the potential to be used therapeutically. When we go to the next slide, I also want to briefly touch on recombinant therapeutics-based tolerance strategies, because those are going hand in hand with the cell-based tolerance strategies at the moment. When we go to the next slide, the main strategy in this regard is co-stimulation blockade. So can we move to the next slide, please? Okay, so as you might be familiar with, for a T cell to be fully activated, it requires two signals. One is through the antigen and T cell receptor, and the other is through co-stimulatory signals. If we block signal 2, then the T cell is not going to be fully activated and undergoes a stage that is called as energy, and this is something that we try to target with specific co-stimulatory blockers. As you can see on the next slide, these antibodies and drugs have been successfully developed. It's actually one of the very few drugs that have made it to the clinics in the past 2 decades in transplantation. And Belatacept, one of those antibodies, was approved for use in kidney transplantation in both the United States and in Europe back in 2011. On the next slide, though, when we think about Belatacept, which has been successfully introduced, and when we ask ourselves, well, does it truly induce tolerance in the clinic so far, then I think the short answer is, well, it does not really work in that way as we have wished for. But it has certainly allowed to reduce conventional immunosuppression to low levels. And when we combine it with cell-based therapy, it still holds tremendous potential for true tolerance induction. So if we go to the next slide, we are currently expanding those strategies with regards to co-stimulation blockade. There's a multitude of co-stimulatory signals, as you can see here, and currently antibodies are developed against several of those targets, and hopefully with those in combination, we will be able to enhance the efficacy of those promising tools. On the next slide, also there is one of the central questions that I wanted to pose for all of those tolerance approaches is how can we actually monitor tolerance, which is critically important when we talk about the diagnostics in transplantation, and when is it safe to actually take a patient off immunosuppression. So when we go to the next slide, you can see that with all this ongoing research that is focusing on reducing immunosuppression and to induce tolerance, we need to have the ability to precisely monitor that immune response. In particular, as factors that affect long-term allograft survival are undetected acute rejection or inadequately treated acute rejection episodes. Chronic rejection is the result of those mostly. And then also there is immunosuppression-related toxicity or the identification of operational tolerance, which again would allow us to withdraw immunosuppression eventually in a subset of patients. On the next slide, you can see that currently still the best method for immune monitoring, or the gold standard, is the use of invasive tissue biopsies, with unfortunately come with side effects, with complications, and are limiting also diagnostic sophistication. And we are therefore currently working more and more to develop blood or urine tests or even other non-invasive tools using mRNA protein expression or cell subsets to profile an alloimmune response. On the next slide, you can see that the quest for tolerance biomarkers really has told us that each organ system has its own specific signature for tolerance, and we have studied tolerance kidney transplant recipients, and you can see here the individual signatures that were be able to obtain and how they were different, significantly different from other tolerant organ entities such as the liver transplant recipients. When we go to the next slide, I think it also became clear with these technologies that the location in which to detect the biomarker signature of tolerance is likely to be the allograft tissue itself, and this goes back to the earlier role that I have shown you with the mechanisms of chimerism, that the graft itself is a major contributing factor to those tolerance phenomena. On the next slide, you can see some of the prospects that we have with regards to a molecular phenotyping of diseased tissues. This has been pioneered by the Alberta program and has shown to significantly advance patient care by improving the diagnostic precision and the mechanistic understanding beyond what is currently achieved with conventional tissue biopsies. On the next slide, you can see what is possibly laying ahead. Those are platforms including proteomics, metabolomics, cell profiling, which will allow for a look into epigenetics, nanoengineering again, and then also systems biology, which will help us to come up with more precise ways to monitor the immune response. On the next slide, I just have summarized for you some of those advancements in molecular diagnostics using these omics platforms that have really shown to offer unique biomarkers of immunological activity or quiescence that can be correlated with rejection and acceptance of grafts in transplantation. On the next slide, you can see the latest advancements that we have seen in this way, which is actually defining T-cell receptor fingerprints of alloreactivity by using deep sequencing approaches. And this here is showing you an example of how these assays are performed, where we are using donor and recipient bloods. We let them react in a mixed lymphocyte reaction. We can identify specifically the clones of cells that will react and try to attack the graft. And then with this deep sequencing fingerprint, we can selectively monitor those alloreactive cells over time. This has actually been applied already, as shown on the next slide, by Megan Sykes' group in some of the tolerant patients from the MGH group. And as shown on the next slide, you can see here clearly how specific alloreactive clones that were identified before transplant are selectively depleted and are disappearing in the patients who are tolerant and therefore don't respond against the donor. And I think this is a very elegant and a very innovative approach that will allow us to specifically monitor non-reactivity in patients long-term post-transplant. So on the next slide, I think it's also important, and it brings us back to my initial notion that if we call it an immune system, it's about time that we start studying it as a system. And this is what Mark Davis from Stanford is claiming, that immunosuppression just is counterintuitive. The immune system naturally regulates itself, and we need to approach this system in a regulatory manner. So on the next slide, you can see that therefore we have really started to model transplant rejection, to work with computational models, to use large data analyses. We have shown on the next slide that we are now able, with computational modeling, predict and suggest what intervention might do to the overall immune response. This is an entire new field in transplant immunology that is moving forward. And on the next slide, you can see how this will lead actually to very personalized treatment efforts where we know the alloreactivity of an individual patient, and then we tailor its immune modulation specifically to this patient, as is currently done in various different examples in tumor immunology very successfully. So on the next slide, you can see that these are very exciting endeavors that we are currently moving along, but all those platforms, as they mature, they will need a holistic strategy using big data concept, which will be critical to understand the interplay of all those multiple factors that truly influence immune regulation and tolerance outcomes. So on the next slide, in the last few minutes, I really want to share with you some future outlooks on where the field might be headed and how tolerance could be implemented in the future. On the next slide, you can see that one area that really I would consider as the latest advances in the field of transplantation has been the new frontier of reconstructive transplantation. As shown on the next slide, that we now perform arm and upper extremity transplants as well as face transplants, as shown on the next slide, really highly successful. And this is an up and about coming field with more and more transplants occurring in many centers around the world. On the next slide, you can see that this form of transplant really for the first time has allowed us to replace like with like tissue and to restore patients back to normalcy, as is shown in the next slide as one of the examples of our patients after full arm transplant, or as shown on the next slide, in the case of face transplantation, we are able, by restoring both form and function, to reintegrate patients into a normal and productive social life after reconstructive transplantation. But on the next slide, you can see that for these certainly life-changing type of transplants, they are not done to save a life, and therefore the risk-benefit equation needs to be very carefully addressed, and particularly again when it comes to balancing medication toxicities against an increase in function, independence, or an improved quality of life. And therefore, as shown on the next slide, our group has worked for many years to come up with strategy again to minimize or avoid immunosuppression by using hematopoietic stem cells to create mixed chimera and then to perform limb transplants in these experimental settings, as you can see here. And this has allowed us to reduce the amount of immunosuppression from triple drug regimens to single drug concepts over time. As shown on the next slide, we have successfully now translated those approaches from the large animal model into an ongoing clinical trial where we perform upper extremity transplants with single immunosuppression. And as shown on the next slide, we are able to do so by using donor bone marrow that we recover from vertebral bodies that are then processed in our stem cell laboratories, and those donor-derived stem cells are then infused 2 weeks post-transplant to regulate the immune response specifically. As shown on the next slide, we have applied this concept so far in an ongoing trial in 13 upper extremity transplants in a total of 8 patients. And as shown in the next slide, this approach has allowed us not only to perform these transplants with a single immunosuppressive agents, but over time has further allowed us to really reduce the amount of immunosuppression to very low levels long-term in these highly immunogenic grafts. On the next slide, you can see here some of the outcome statistics where we see 1 to 3 rejection episodes in the first year, but about 40% of those are actually reversible with treatment of topical agents towards the skin, which is the main target of rejection only, without the requirement of any additional systemic immunosuppression. And so far in none of those patients we have seen any infectious complications. On the next slide, you can see that these grafts also are unique in a way that they contain now, for the first time in the history of transplantation, vascularized bone and the vascularized bone marrow niche. So now we are actually dealing with a graft that brings along this donor-derived hematopoietic stem cell niche and would allow for chimerism-inducing strategies much more so probably than any solid organ transplant would do. If we go to the next slide, as I already mentioned, this unique vascularized bone marrow really is a persistent source of donor, not only donor antigen and stem cells, but also promotes for cell-based tolerance-inducing strategies. And therefore, we might be able to lead the way in tolerance induction with these type of transplants eventually in the future. If we look at the next slide, based on these hypotheses and unique aspects of the transplants, we have actually recently developed a new protocol in large animal models that would allow us to stop all immunosuppression about 30 days post-transplant. This is across a complete MHC mismatch, and as shown on the next slide, we use this by performing heterotopic limb transplant in a swine model, a very stringent preclinical model, where we transplant all the components of a limb, including the skin, and then have the skin exteriorized to monitor it for rejection. And as shown on the next slide, this protocol really for the first time has allowed us to perform these type of transplants without the need of long-term immunosuppression. And this is for the first time, as shown on the next slide also, that we are able to induce specific immune quiescence against the donor, whereas there's a normal response against third party. And you can see here the skin paddle in animals that were off immunosuppression for more than a year. So with these advances, we really think, as shown on the next slide, that without the occurrence of either acute rejection within the skin or chronic lesions within the vessels, we are able to, as stated in this last slide here, we are able to induce immune tolerance also in a setting of VCA, probably in the not too distant future. And with regards to time, I think I probably want to stop here and give us the chance to take some questions from the audience.
Dr. Brandacher, thank you for a fantastic presentation. Wow, that's amazing work that's being done, and I'm not going to pretend to understand every single thing you said, but it's absolutely amazing how intricate and how complicated things can get in trying to manage immunity. For all of our audience participants, this is the time that we can take your questions. On the bottom left-hand corner, you should see a little chat icon, and if you click on that, you can type in your questions, and I will pose them for you to Dr. Brandacher. And while we are going through those questions, we will have a poll up for those of you listening in groups today. Please complete the poll as to how many people are in your group. Dr. Brandacher, the first question is, how could tolerance strategies help with the problem of organ shortage?
Well, thank you very much. I think that's a very important question. One thing that I think tolerance really could help with regards to organ shortage is that we always talk about one transplant for life, but are currently really limited with the level of what we call a graft half-life that ranges anywhere in a best scenario around 16 years at this point for a kidney transplant. And I think if we were to induce true immune tolerance, and if we live up to this definition that I've shared with you, that would prevent any immune response long-term, and also the lack of chronic rejection, that we could eventually live up to this promise of a graft for life, and thereby hopefully reduce significantly the need for repeat transplants, and thereby help alleviate the waitlist burden that we're currently facing.
Great, yeah, that's a really good point. The next question is, if someone has an autoimmune indication for transplant, for example, lupus, does that impact the ability to undergo these protocols?
Not necessarily. For some of those strategies, we really think that we would be also able to kind of reboot the immune system. And some of those strategies are actually used to actually treat refractory autoimmune disease, where auto bone marrow transplants are currently pursued in patients that have very, very challenging cases of autoimmune diseases. And by performing a bone marrow transplant where your own bone marrow is giving back after this conditioning regimen, it has actually been shown that there is significant improvement, or in some instances treatment, or complete alleviation of the autoimmune disease. So I think it could be actually something where we could address both issues with one strategy.
Oh, wow, that's pretty amazing. You had mentioned earlier on in your presentation that the patient has to undergo some conditioning regimens that could be toxic in themselves. And what types of side effects would you potentially see with that? When you mean it's toxic, what does that actually translate to?
Yeah, so the issue with the conditioning regimens, and some of them are really harsh, is the use of irradiation and myeloablation in some instances. So this could really lead to issues with severe neutropenia, infectious complications during that time until the immune system is reconstituted. So this is one of the main areas actually currently in tolerance, where we try to move away from those myeloablative regimens and replace them with what's called non-myeloablative regimens by adding on biologic agents such as the costimulatory blockers, or augment the treatment regimens with regulatory cells. And both of those strategies have actually shown that they allow to reduce the amount of conditioning necessary for the bone marrow to engraft and to establish stable mixed chimerism.
Okay. Now, in terms of induction tolerance, has this been done in any patients that are undergoing a second transplant?
Not to my knowledge. So as you have seen, the numbers are fairly small and the selection criteria are very stringent. This is, however, a very important question, and I think if we want to fulfill the true potential of tolerance, then eventually we want to have protocols in place that would allow us to induce tolerance in patients not only for a second transplant, but also in patients that have already been transplanted and are currently on conventional immunosuppression, because probably then everyone would say, well, I also want to be off immunosuppression, and is there anything that can be done? So this is what is currently a main emphasis of many centers, where we try to develop what is called delayed tolerance protocols, where we would be able to again reset the clock at a later stage post-transplant. And this is why efforts to actually bank donor-derived bone marrow are so critically important, because you want to go back and have the ability to have cells from your donor to induce those concepts eventually later on. And also, it's an important aspect of delayed tolerance, because around the time of transplantation is really probably the most inopportune time to play with the immune system, because there is so many factors going on. We have ischemia reperfusion. We have a lot of inflammation from the surgery itself ongoing. So the immune system is geared up on many levels, and this is the time that we try to selectively downregulate it against the donor. So this might be actually a very inopportune time to do it. So the thought process is, if we were to undergo a transplant, have everything calmed down, ischemia reperfusion subside, the graft is healed in, and everything is stable and uneventful, that then probably the time point to try to manipulate the immune system is much more successful than it could be early on. And this is, again, another reason why we work on those delayed tolerance strategies.
So to your point about trying to work on increasing the banking of bone marrow at this point in time in order to allow for the delayed treatment down the line as research has advanced and it's possible to do so. Hypothetically, knowing that umbilical cord banking has been around for much longer, probably, do you think hypothetically if, say, from a donor that bone marrow wasn't available, but there was some umbilical cord that was still banked from that particular donor, that could also provide the cells needed? Or
absolutely. As long as I think that the main thing is we need hematopoietic stem cells from this particular donor, and if those can be obtained from any source, there's some intricate, and this is getting very technical, of course, where there's some advantages of using truly bone marrow rather than mobilized cells, also in the protocols currently available. But I'm sure that the protocols can be adapted in any way or form at some point, as long as these CD34 positive hematopoietic stem cells are available.
Now, you referenced graft versus host disease. In a lot of, typically in full bone marrow transplant, obviously that is a high risk. Is the percentage of risk just as high in in a bone marrow infusion? Because you're not replacing the full bone marrow, right, in this scenario?
Exactly, not in all protocols. So some of them, they turn the patient into a full chimera, which means it's 100% donor. And in those were also the protocols where we have seen instances of GVHD. But overall, the strategies are designed in a way to have mixed chimeras so that both of those populations would keep each other in check and minimize the chances of GVHD.
Great. Dr. Brandacher, I have one last question before we wrap it up. The last question is, you had mentioned earlier on in the presentation as well that currently it's only done in living donors as those surgeries are scheduled, so you know the time of the surgery. So how long does it actually take to get the recipient ready with these protocols? What's the lead-up time?
Yeah, so this depends from protocol to protocol, but on average, anywhere between 3 to 10 days, that's the requirement of the current protocols to pre-treat a recipient.
Okay, all right. Well, Dr. Brandacher, thank you so much for a very educational and fantastic and informative webinar. We have a lot to learn, and we appreciate you sharing your expertise. I'll turn it back to Corey to close us out.
Thank you very much.
Thank you. We'd like to extend our sincere thanks once again to Dr. Brandacher for his time and for a remarkable presentation today. To all of our participants, we thank you for your time as well, and we wish you a wonderful rest of your week. Take care.